Good morning. Thank you for joining us for another episode in the Celtx webinar series. My name is Paul Newhouse with the Client Services Department. Today we're going to be talking to you a little bit about the heart and a promising tool in heart health, maintenance and recovery with MSCs, mesenchymal stem cells. Joining me today is one of our valued Celtx clients, and actually he's a retired internal medicine physician, Dr. Richard Taylor, joining us from Oregon this morning. Dr. Taylor, how are you doing?
Good, thank you. Thanks for having me.
Good. Well, we'll get with Dr. Taylor here shortly, but we'll kind of jump into the presentation. Today we'll be covering a handful of topics. We'll give you a little bit of an overview of heart disease. We'll talk about heart attacks and how the body responds to those. Talk a little bit more about stem cells and the properties of MSCs, how those are applicable with heart issues. We'll take a look at a few external studies, what researchers are using as far as MSCs and heart issues. We'll circle back with Dr. Taylor, learn a lot more about him and his story, and we'll talk finally about some tools we can use to promote heart health. So heart disease overview. If you weren't aware, this month, February, is actually American Heart Month. So we'll be looking at ways to keep your heart healthy this month and beyond. So actually this number here on screen, pretty big number there, 805,000. According to the CDC, that is the number of people who die each and every year of heart attacks just in the US alone. So a really staggering figure there. And of course, that's only in the US. If you looked at people worldwide, of course, that number would be significantly bigger. So heart attacks, heart disease, heart health, all very important topics to discuss today. So what happens when someone has a heart attack? How does the body respond? Well, of course, when someone has a heart attack, generally speaking, what's happening is a blood clot is stopping the flow of blood to a portion of the heart muscle. This lack of blood flow deprives the heart tissues of oxygen, which causes cells to die. So how does the body respond during that acute phase, or in other words, immediately following that event? Well, the immune system actually helps to respond to the injury, bringing cytokines and inflammatory factors and immune cells into the area. Process clears out dead cells and helps to repair the damage as much as it can. So unfortunately, the heart tissue doesn't function as well as the original tissue because it's been damaged. The result of a heart attack can lead to scar tissue, fibrosis, damage to the cardiac nerves, and also changes in circulation. And this creates several problems. It can lead to irregular heartbeats, weak or ineffectual pumping of the heart, thinning of the ventricle walls, poor blood flow within the heart. So the long-term consequences of poor tissue healing and resulting impaired heart function significantly decrease one's quality of life. So when we're talking about the heart, we're talking about autoimmune diseases or anything else with Celtx, that's always our primary focus, is maintaining or ideally improving one's quality of life. So as most of you know who have tuned into some of our webinars in the past and have been following along with Celtx, we work with a type of stem cell known as the mesenchymal stem cell, or MSC for short. So today, obviously, we're talking about how MSCs can be a promising tool for combating and healing problems that follow heart attacks. And this is due to the unique properties that MSCs display. So MSCs are the body's natural healing cells. They travel through the circulatory system and they can home to areas that are damaged or in need of repair. They deliver healing factors that can regenerate new cells and tissues. We'll talk a little bit more about that. So this goes into some of the properties of MSCs that we've covered in all of our webinar episodes. The reason being is because they're very important to understand as far as what MSCs do and how they can be applicable not just for heart issues, but for others as well. So MSCs are immunomodulatory, basically meaning that they can regulate immune system functioning and reduce inflammation by inhibiting T cell activity. As I mentioned in the previous slide, they home and travel to sites of injury or in need of repair. And very importantly for the heart, they're angiogenic, meaning they can develop new blood vessels and improve blood flow, helping oxygen get to the heart and to other organs that are needed. MSCs self-renew and regenerate, so they can produce more stem cells where they're needed. They promote cell survival and repair damaged cells, and they're also multipotent, meaning they have the ability to differentiate into multiple cell types. So we have this multipotency at the end, and I've talked about this in all the webinar episodes. The initial understanding of MSCs was that they were a blank stem cell and they could turn into different cell types. Whereas now we know more about MSCs, that they promote various other activities by signaling, releasing various molecules, cytokines, and other things into the body that kind of propagate these repair and regeneration mechanisms. So not just about differentiation capability. So how does this apply to heart disease and heart attack recovery? Well, the self-regenerative and multipotent properties of MSCs allow them to regenerate more functional tissue. And as I just mentioned and highlighted, this is very important. The MSCs secrete factors that aid in the recovery process. Antifibrotic factors can limit scar tissue formation, and pro-angiogenic factors can increase vasculature and circulation. Very important when healing's taking place. MSCs reduce the inflammation that can cause blood clots to occur, and MSCs can trigger other regenerative cells near the damaged area to mature and function. So when we're talking about putting MSCs into the body, obviously these MSCs are going in and they're doing work and they're communicating with one another. But it's also important to note that they are also communicating with the cells that are already in the body, the tissues already in the body that may be dormant or dysfunctional as a result of an event like a heart attack or some type of disease state. So everyone has MSCs in their body, but the body's native population may be inadequate at times of an overwhelming injury, like a heart attack. The self-replicating properties of MSCs allow them to be cultured in large numbers and cryopreserved, which is of course what we do here at Celtex, in preparation for such injuries. So we'll take a look at a couple external studies that have been done just to give you a better idea of what's going out there in the scientific community. So stem cells, MSCs, this is nothing new for the scientific community. They've been at the center of several scientific studies dedicated to addressing heart disease and other heart-related issues. Looking at one preclinical study that indicated benefits to animals with artificially induced heart attacks who were then treated with MSCs. Researchers found that MSCs were able to reduce inflammation after the heart attack by decreasing the inflammatory cytokines. And they found that MSCs reduced the thinning of the heart muscle that frequently follows a heart attack. Another study took a look at supporting the notion that MSC's primary benefit comes from the paracrine and anti-inflammatory factors of the secretome. So the secretome is basically a collective term for all those various factors, cytokines, anti-inflammatory factors, all these terms that we've been using. The secretome is the collective term for all those things that are released that propagate some of these repair and regenerative mechanisms that we're discussing. So the anti-inflammatory or anti-apoptotic, tough word there, basically means preventing cell death, and growth factors inducing properties were found to be more helpful than MSCs directly replacing cardiac cells. And then finally, looking at a meta-analysis, or basically a overview combining several clinical studies at one time in 2007, suggested that the approach of using MSCs is safe and feasible with benefits in left ventricular function in humans. So again, a meta-analysis is looking at many, many clinical studies that have been done and looking at the overall effects of all the studies collectively. So now that we've talked a little bit more about heart attacks, some of the properties of MSCs, we'll discuss a specific example with Dr. Taylor looking at his story. This will be a very interesting story because he has a very unique case. And as someone who's been through this and as a former physician, he can speak in great detail about this situation. So, Dr. Taylor, happy to welcome you back into the discussion here. So, if you would, maybe just introduce yourself to the audience here, about your background, and then we'll start by discussing kind of what led you to look into Celtex as an option and a bit of a background on your particular medical issue.
Okay, thank you. My name's Richard Taylor. I practiced rural medicine in Texas for, I don't know, 20 plus years. And when I was 42 years old, I woke up in the early morning hours with severe ripping pain between my shoulder blades. And make a long story short, I had suffered what is called an aortic dissection, which technically is not a cardiac issue. It's a vascular issue, and it's the largest blood vessel in your body that exits the heart and traverses through the thorax or chest cavity down into the abdomen, and then bifurcates in the pelvis and makes its way down into the legs and thighs as the femoral arteries and whatnot. Probably the most famous person who had a aortic dissection was John Ritter, and he died from his in the emergency room. So they're very serious, and they're frequently lethal. I managed to survive mine. Now I'm going to give you a little bit of an anatomy lesson, not too in depth, and a little bit of a pathology lesson in terms of what aortic dissections naturally progress and do if you survive them initially, which I did. So the aorta is a 3-layered blood vessel, and the layers are kind of laminated. You have an inner smooth muscle layer, a middle muscular layer, and an outer fibrous layer. And essentially what happens in a dissection is the inner smooth muscle layer delaminates or separates from the middle muscular layer, and blood is allowed to seep behind that layer, and you end up with an aorta that looks like a double-barreled shotgun. It's got 2 lumens, in other words, instead of one. Instead of one opening and one vessel, you have 2. And that, of course, alters the blood flow to all of the organs that the aorta supplies, which is just about every organ in your body. Now, over time, the natural course or natural history of that condition is for the aorta to form aneurysms, weaken, expand out, and then if it gets to the point of rupture, that's instant death. So one of the things that a survivor of an aortic dissection must do is every 6 months to a year, you need a CAT scan or an MRA to evaluate the aorta and make sure that it is not expanding and forming aneurysms, because that is typically how you will die from this condition, if that aneurysm gets too big and ruptures. So I survived, went home, and was getting my annual CAT scans, and about 4 years into this, after the initial dissection, it was noted that my aorta was starting to form a pretty large aneurysm up in the chest. So long story short, the method of repairing that was to cut the patient open, in this case, do a thoracotomy, and repair the aneurysm with a Dacron graft. And without going into it, it's extremely invasive, extremely long recovery, extremely painful, but effective. So I had that done at age 46, and went on with my life. And then again, about 4 years after that, at about age 50, it happened again. This time, though, the aorta tore upstream, and I had another dissection, which prompted emergency surgery. I had to cracked my chest open. I was on the operating table for 12 hours and do another Dacron repair. So my aorta and the entire thoracic cavity is wrapped in Dacron. It will not form an aneurysm, but again, extremely invasive, long recovery type surgery. Now, fast forward to 2016, 2016, I went in for my routine scans, and guess what? I'm forming aneurysms now downstream in the aorta that's in the abdomen, the portion of the aorta that's in the abdomen. So I'm looking at more surgery, but the problem now is it's so extensive they can only repair part of the problem. They can't repair the whole thing. It would be too invasive and too much surgery for a human body to endure. Mm-hmm. So that's when I started researching alternatives, and I knew a little bit about stem cells and began to do research specifically for stem cells and aortic dissections. There weren't many studies. I found a couple that were done. I think one of them was in Japan, and I think the other one was a German study. Don't hold me to that. It's been a few years ago, but I met with the stem cell people at Celtex and decided to go ahead with it, essentially because I had nothing to lose and everything to gain. So if it didn't work, well, I was out some money, and that was really it, out some money and time. So I did the initial harvest and the cloning process and the infusion, and it didn't fix my dissection, but what it did do, and this is where it's been very worthwhile for me, is it slowed the progression of that aneurysm formation down in the abdominal aorta remarkably, slowed it way down to the point where technology caught up and I was able to do a much less, albeit experimental procedure last summer, 2021, at the University of Texas Southwestern in Dallas, that involved a couple of small little 1/4-inch incisions in my groin and placing stenting materials in the entire aortic vessel in the abdomen. So I have no more areas for that aorta to form aneurysms because the entire thing's stented. But had I wanted to do that 5 years, 6 years prior, the technology wasn't there yet. So in a situation where I was facing certain surgery, and the surgeons were urgent about that, their comment to me was, you need to do this surgery within the next 3 to 6 months maximum, or you'll be dead. But we can't completely fix the problem even then. Mm-hmm. So, I just thought, well, I'm gonna go outside the box. Much to, they weren't happy with me. Let's put it this way: the surgeons weren't, but I don't care. I had enough medical knowledge and enough belief in this that this really was my best option, and it prolonged surgery for 5 years, and that was enough time for the stenting technology for what I have to catch up and at least get into a study, like a clinical stage 3 clinical trial study, which is the last phase of a study. So in other words, it's working pretty good. We're in the 3rd stage. You're probably going to do well with this type of thing. Sure. So I had it done in August, and here I am. Hopefully I'll die from something else. Anyway.
Yeah, no, that's a really, really great story and really great detail. So if I could, let's kind of walk back through that and highlight a couple items there, Dr. Taylor. So going back in the beginning, and I remember you and I meeting here in Houston all those years ago, we were talking a little bit about, kind of your research process. You came across a couple studies, one in Japan, in Germany. So if you can remember going back to that starting point, what was it about Celltex or what we were offering that kind of drew you in and ultimately convinced you that this was your way to go?
Well, okay, so both studies were not, they were somewhat conclusive, but they weren't overwhelmingly like this absolutely works. It was the consensus was this may be beneficial, may.
Mm-hmm.
So there was the possibility of a good outcome, number one. Number two, the thing I liked about Celltex was the cloning process, and maybe that's not, well, that is the right word, the cloning process.
Culturing, multiplying. Yeah, we use all those terms synonymously.
Yeah. Okay. Numbers, in terms of sheer numbers of stem cells, are really important in outcomes. In other words, you've got all these people out there, oh, we're doing stem cells in our offices. Yeah, you are. And it's like treating a dental abscess with 25 milligrams of penicillin. It ain't going to work. Mm-hmm. Okay. You got to have 500 milligrams of penicillin. Well, same goes for stem cells in my estimation. You've got to have hundreds of millions of them, not 40 or 50,000 of them. Okay. Which is what you get in an office procedure if you're lucky. So the fact that we could multiply these up to therapeutic numbers, that made a big difference to me. And then of course I got to meet Dr. Jones, and who doesn't like Dr. Jones, man? He's one of the greatest. And but strictly from a medical standpoint, it was the fact that this may be beneficial. The jury was out at that time, but it wasn't a conclusion that it was not beneficial. It may be, and then the fact that I could get the numbers of cells that it would take to do this through your process at Celltex, if that makes sense.
Absolutely. Absolutely. So we get started with the process. And actually, I believe in addition to the intravenous infusion, we also did a couple superficial injections right at the site as well, didn't we?
Yeah, we did. You have a good memory. So when I had my first surgery to repair the aortic aneurysm up in the chest, the approach for that surgery was what's called a lateral thoracotomy, which is a medical term meaning opening the thorax from the side. So the incision is it's about 2 feet long, starts at mm-hmm. my tip of my shoulder blade in the back and comes around to the sternum in the front, right between, I think the 5th and 6th ribs. Don't hold me to that. And the ribs are spread. Well, the problem is the intercostal nerves run right along the top of the ribs, and my intercostal nerves got damaged during that process. And it's just part of the process. You expect that. That's an expected problem with the type of surgery I had. Hard not to do that. But it created a really chronic, painful situation in between my ribs, almost like having shingles all the time. That's the same nerve involved in shingles, okay? So we injected the actual intercostal nerve area at the affected level, and I'm not in any pain now. That really worked well. Like the sensation is slightly altered in between the ribs. I'm rubbing it right here, but it's not noticeable unless I go rubbing on it, and it doesn't mm-hmm. hurt anymore. So that's a good point. I should have mentioned that. That was a complete success in terms of getting rid of the intercostal neuralgia, if you will, the nerve pain in that nerve.
Yeah. Um, so those surgeons who weren't too happy with you, what was their tone? How did their tune change in the years that followed? You know, after they realized, you know, okay, here's what we thought at the beginning. Did they change their minds at all, or would they not concede that?
No, they just their position was, well, you know, I don't know what happened here. Maybe it was the stem cells. Uh, you know, they weren't going to admit defeat. So it's okay. They just kind of scratched their heads and shrugged their shoulders and said, we don't know. But they were the same surgeons who weren't too happy with me when I went with the experimental stenting either. they were really wanting to cut me open a third time and do a half repair. And I'm like, well, a half repair is no good. You may as well have no repair at this point, because if that thing pops, you're just as dead with a half repair as you are with a no repair. So they weren't terribly thrilled with my decision to go with the experimental. However, it was the best thing I did. You know, it took about 3 or 4 months to get over the surgery just to kind of feel reasonable again. But man, I've got a bionic aorta now. I mean, it's not going anywhere. So yeah, and you know, and like I said, I highly unlikely I would have made it to this point to take advantage of that experimental surgery without Celtex and the stem cell treatment. Not likely at all.
So just to restate that, essentially what stem cells did in your case, although it didn't fix the aortic dissection, of course, but it gave you this bridge of 5 years or so from that point in time where you were, in order to enable you to get this experimental procedure that wasn't available at the time, but has now been very successful for you.
Yeah, that's correct. And I anticipate that this procedure I had done, it will be FDA approved most likely within the next couple of years, and you'll start to see it used a lot more. But like I said, 5 years ago, no, it was kind of in its early clinical trials, and I'm not sure I'd have been able to get into that trial. Probably not at that point.
Okay. So, and one last clarifying point. So if you could, Dr. Taylor, you know, in a minute or two, just to kind of summarize, so everyone has a clear picture, the nature of the surgery you had done versus the nature of the surgery that was proposed to you all those years, and the differences in what, you know, your recovery look like in reality versus what your recovery would have looked like if you did the surgery that they were telling you to do along.
Okay, so the old, let's call it the open procedure, where they cut you open.
Yes.
Arguably, and if you talk to vascular guys, vascular surgeons, this is arguably the most invasive surgery that the human body can endure. Arguably, but you know, there's a good argument. Yeah, that's the worst you could endure. So it's basically reopening everything from the tip of the scapula in the back down through the thorax, and then extending it on down into the abdomen. Huge incision. Long surgery, and most importantly, it wasn't going to be able to go low enough into the pelvis to correct the whole problem of the aneurysm formation in the aorta and then the iliac arteries, which bifurcate off the aorta. Okay, they're downstream from the aorta. So majorly invasive, probably a year to recover. A year now, not 6 months or 3 months, a year.
Wow.
Okay. Whereas the surgery that I had done was all done through little scopes, 3 tiny incisions, one on each side of the groin, about 1/4 of an inch long, and one up here in the brachial artery here by the biceps muscle, just probably a 2-inch long, little tiny incision. And then instruments are run down through those incisions, and everything is manipulated with instruments under ultrasound guidance.
That's incredible.
And yeah, and so now the recovery, it took longer than I would have expected. I didn't feel normal for about 3 months. But I wasn't bedridden. I could get up, I could get around, I could do a few things. So it wasn't horrible. I just didn't feel real good. Didn't have energy and just kind of fatigued and blah, for about 3 months. But by that 4th month, I was really back to normal. I mean, I'm not going to go run a marathon or go pump iron in the gym anymore. But you know what? I can go to the airport. I can get on an airplane. I can go to the grocery store. I can go out here on my tree farm and run a chainsaw for a couple of hours. So that's okay, considering what I've been through. That's reasonable. I can function.
Sure. So yeah. So now just to kind of wrap things up with your story, you're feeling better. You're out there in Oregon in retirement on a tree farm, doing some things. Activity levels are good, and you're doing well.
Yes, I'm going to call this a pretty big success, considering what my aorta looked like. Yes, sure. Big success.
Sure.
Yeah.
Okay. Well, that's a great story. And I, as we've discussed, Dr. Taylor, I was really familiar with kind of chapter 1 of that story. And then we just kind of talked about chapter 2 more recently with this surgery, but it's a really neat story. I think it speaks to, some of the limits of what stem cells can do, which we at Celtex are perfectly fine acknowledging that stem cells can't do everything. They can't cure everything. They're just but one piece to the wellness puzzle. But in your case, what they were able to do was stabilize you and bridge the gap until, a less invasive procedure was available to you to help you out. So it's a different
well said. That's exactly right. Yep.
Yeah, a different success story than we're used to telling, but I think one that's very important for people to hear. So we really appreciate you taking the time to share it with us.
My pleasure. Thank you. I hope that helps your audience.
Yeah, I think so. We'll go through a few more slides if you want to stick with us here, Dr. Taylor. We'll go through a few more slides. This is kind of our closing section. So again, just to reiterate, medicine is constantly changing. The procedures are a big part of what continues to advance, along with stem cells and other components of medicine and science. So having one's stem cells banked is a way to be prepared for when these exciting changes arrive. So our banking options, of course, what you've done, Dr. Taylor, is what we now call our foundation bank. And that's when you just initially bank the cells, and those from that one-time extraction procedure are available to someone, an essentially infinite supply of stem cells as many times as are needed for present and future therapies. And of course, as part of this banking process, we have rigorous quality and sterility testing that's done in the lab. We're isolating and culturing those MSCs to create that bank, and then those are securely cryopreserved or banked at -300 degrees. What you may not be familiar with, Dr. Taylor, is actually a new offering that we have, and it's called Safeguard Banking. And essentially what this is refreezing or banking the cells that we prepare for a therapy, but putting them back in the bank so that they're essentially ready for immediate use. So these cells can be ready within 24 to 48 hours notice. So we basically go through that prep time of creating the cells for therapy, put them back in the bank, and then in the event of some type of severe medical incident, talking about heart attacks here, of course, but also things like TBIs, God forbid, car accidents, lung damage associated with certain conditions, strokes, things like that. These cells can be available on very short notice, as opposed to that 3-week or so lead time that we typically have to produce cells. So that's called safeguard banking. So going into a little bit to Q&A, I see a few questions here that are actually for you, Dr. Taylor, if you don't mind. I'll share those with you here in a second. For others that are submitting questions specific to certain heart issues, others that submitted questions prior to the webinar, I saw we had a few on ejection fractions, AFib, coronary artery bypass grafts. I won't be addressing those because I myself am not the physician to address those. So we'll get with our medical team and we will follow up with everyone who submitted questions and get you answers to those. But a couple here, Dr. Taylor, that are actually directed to you. Have one woman asking your thoughts on redoing IVs or an IV maintenance just for anti-aging. Do you have any thoughts on that based on your own experience?
Well, we were talking about that before the webinar. I think there's something to that. Now, am I up on any current studies? I'm not, even though there may be. It's not something I've read recently, but I think there's some credence to that. In fact, when I was getting treatment, I've done the IV treatments twice. And at one of those treatments, there was a lady there doing the same, and that's exactly why she was doing it. She said, I just feel so much better when I do this. I just do it once a year, and as a sort of a preventive maintenance tool. Mm-hmm. Now, is that harmful? I can't imagine why. First, do no harm, right? Is it beneficial? Well, sure. Those stem cells are going to find areas to migrate and differentiate and do their thing wherever there might be a need in the body with cytokine release or what have you. So I don't, and my wife was talking about that the other day, wanting to do just that. She says, I think I just want to go back down there and, once a year or once every other year and just do an IV treatment just for health's sake.
Yeah, well, we call them different from the ones that everyone's been hearing about the last couple of years. We call them boosters. So
boosters.
Everyone's heard of the booster shot. This is a booster therapy. Same concept.
Well, yeah. Let me just say, it stands to reason. And I know that after I had both treatments, I just felt better in terms of general well-being, if that makes sense.
Yeah, we actually had another gentleman ask, did you notice anything else after MSC? So anything else specific that you noticed separate and apart from the aortic issue?
Yes, strange. Prior to MSCs, I had green eyes. My eyes are now blue. Don't ask, just, it changed the color of my eyes from green to blue. I don't know. It just did.
Was that a welcome cosmetic change for you then? Do you like your new blue eye?
Well, I don't know if I'm on, but look at that face. Anything's a welcome cosmetic change to that mug. So yeah, sure. Yeah. But yeah, it was strange. I also noticed, I want to say I was having some knee pains that kind of went away. Just sort of aches and pains got better. I just felt better. But yeah, the eye color definitely. I have blue eyes, and I had green eyes my entire life prior. Yeah. So,
yeah. Honestly, it pairs very well with this barcode on screen right now that people can scan to see if stem cell banking is right for them. So that's something that you can scan with your phones. This QR code, I'll leave that up here for a few more seconds. If anyone else has any questions, we'll keep talking here for a few more minutes. But if there are other questions that you'd like to submit, and again, I'd just like to repeat that any questions that you've submitted during the webinar that haven't been answered prior to the webinar that are specific to heart issues, we will follow up with you on those. So I don't want you to think that we're ignoring those questions, but we'll get with the medical team and get more appropriate responses to those. Anyone who does want to get in touch with our team, you can send us an email at webinar@celtexbank.com. As we've mentioned a couple times, the first step is always banking one stem cell. So that's where the process would start. And then finally, we will have our next episode in our webinar series next month, Thursday, March the 3rd at 11 a.m. Central. Next month is MS Awareness Month. So we'll be talking about MS, multiple sclerosis. We'll probably have a guest or two at that presentation. But that does conclude our heart presentation for today. Dr. Taylor, do you have any closing comments for everybody?
Well, I would just say this. At the very least, bank your stem cells. Get the harvest, get them banked, and then they're there if you want them. It's not expensive to do that, and it creates an option for you. And as you mentioned earlier, Paul, with the new program for really kind of quick usage within 48 hours.
Safeguard banking. Mm-hmm.
Yeah, safeguard banking. Thank you. Boy, that's when you may really need it. And, if they're sitting there in the bank, safeguarded, you can get them quick where they will do you some good.
Yeah.
And to me, that's a really nice, inexpensive insurance policy, if you will.
Yeah.
That's how I would look at that.
Yeah. Well, I certainly would agree with those comments. And Dr. Taylor, once again, it's been a pleasure talking to you. And of course, been a pleasure talking to you all these years and keeping up with you. So thanks so much for taking the time, joining us today and telling your story. And we'll look forward to talking to you again soon. We'll look forward to seeing everybody else at our next webinar presentation next month, Thursday, March 3rd at 11 a.m. So Dr. Taylor, take care, have a good day, and we'll see everyone else again soon.